Good night. I'm Marvin Shuttleworth, my partner, Mr. Fabian Spencer and Davian Smith, playing my patient, Carlton Stiff. Tonight I'll be doing a long case trauma assessment for a patient who reportedly fell from a tree, got up, made a few steps, and collapsed again. Me and my partner will be taking BSI precautions: gloves, face mask, eye protection. Arriving on the scene will ensure that the scene is safe. Note the mechanism of injury. Patient fell from tree. It's only one patient. We will call for ALS support since this patient is unconscious, and due to the mechanism of injury, C-spine protection is a must. Approaching the patient and forming my general impression is an adult male lying in the left lateral recovery position. Patient appears unaware of our presence. Patient is breathing, and there is some bleeding around the patient's right hand section. Approaching the patient in the line of sight if the patient was aware of us approaching. Sir, if you can hear me, please don't move your head. Sir, Spencer, some stabilize the head. Sir, can you hear me? Patient does not reply. Painful stimuli, the patient groans. Okay. Alright, this patient is on lateral position, so I will quickly check this patient back. Smith, get the backboard, please. Quickly make a quick assessment of the patient's spine and rear section, since the patient is now on the side. So I align the backboard to the patient. Alright, we are going to interchange hands. From here, we're going to log roll the patient onto the spine board. Go down and up a little and align patient onto the backboard. So we'll go down and then up. Alright, patient is aligned on the backboard. At this time I'll assess the patient's airway. I'll ask my partner, let me just get this out on it. Just a little bit more. Take time, slide it out. Slide it out. Alright. I'll ask my partner to use the jaw thrust maneuver to open the patient's airway. At this time, the patient was reported to vomit, so let's quickly turn to the side, turn backboard to the side. We'll quickly rotate to the side, to this side. Watch this. Rotate the patient to the side. Allow the vomit to drain from the patient's mouth. Okay, as soon as the patient has stopped vomiting, we'll get him back onto the backboard and quickly align him to the backboard. Mr. Smith, get the suction. Ensure that we get a suction of at least 300 millimeter mercury. We're going to measure from his mouth to his ear. Insert the suction after measure. Suction on the way out for no more than 10 seconds, okay? At this time, I'll quickly get the pulse oximeter for the pulse oximeter reading for the patient, because I'll be giving this patient oxygen after suctioning. Alright, at this time we have a pulse ox reading of 92%. So, alright, get the O2. We want to give him at least 12 liters per minute via the non-rebreather mask, alright? Okay, this patient is having a gag reflex, so one moment let me just give the NPA. I'll put on the NPA before the patient, before my partner put on the bag valve mask. I'll measure from the corner of the mouth to the ears. Insert it with the bevel facing the septum in the right nostril, and use water soluble lubricant to insert the NPA. Alright, patient will be going on 12 liters of oxygen per minute. Alright, I'll assess this patient's breathing. Breathing, auscultate patient's anterior, lower, and mid-axillary. Okay, we have clear lung sounds. This patient breathing appears a bit rapid, however there is adequate chest rise. Alright, checking this patient's pulse, checking both radial pulse, ensuring that we are comparing both of them. Pulse feels a bit rapid and a bit weak. Okay, assessing the skin color and condition. Skin is a bit pale, it's, clammy and cool. Get the thermometer, I'll do a temperature check. Okay, please for the pupil gauge. We'll check the pupil gauge for the patient. Okay. Pupil respond a bit low to the light. I'll do a cap refill for this patient. Cap refill is sluggish. Alright. Patient is on oxygen, so we will continue applying. At this time, I'll note that the patient has a bleeding starting on his right hand from a laceration. Bleeding appears to be getting a bit active now, so Mr. Smith, give me the 4x4 gauze and the 4x4 dressing with the bandage. Okay, I'll inspect the wound and ensure that there is nothing in the wound. And direct pressure and elevation. Alright. After which I'll instruct Mr. Smith to just take over and finish adding this dressing and apply bandages to the dressing. Okay. This patient now, I'll do a rapid trauma scan for this patient. He's a priority patient that we will have to load and go immediately. Mr. Smith. Okay, at this time our partner has finished dressing the wound to the patient's hand. I'll do a rapid head-to-toe scan for this patient, checking the head. And I'll be checking for decap details, which is deformity, contusions, abrasions, punctures or penetration, burns, lacerations, tenderness, or swelling. I'll assess the patient's head, patient's eyes, zygomas, maxillae, mandible. Quickly check the patient's ear, checking the neck, or JVD, jugular vein distension, or tracheal deviation. Alright, Mr. Smith, please give me the C color. Alright, at this time, I would measure the C color, measure the neck for the patient, adjust the C color, and apply the C color to this patient. I'll check the chest, checking for decap BTLS. I'll assess the 4 quadrants of the patient's abdomen. Assessing the hips. At this time, I'll observe that the patient has a paraprism. So this indicates that the patient is suffering from some spinal cord damage. Assess both extremities. At this time, the left leg appears to be shorter than the right one, and there's swelling to the humerus region of the patient's leg. Okay, we will deal with that shortly. Alright, at this time I'll secure the patient's head with the head block so my partner, the head, can be freed. This patient is priority patient, as I stated, so we will now transfer this patient to the ambulance. In the ambulance, I will now start getting sample history, but since the patient is unconscious and there was no family member, I'll just start doing a set of baseline vitals for this patient. While doing the baseline vitals, I can have one of my partner. The ideal thing for this leg would be a traction splint. Measure the right leg and use the traction splint to do inline traction for the leg to get it to the right length. However, since we don't have none, I'll just have them secure both legs together and secure it to the backboard. Alright, so Mr. Smith will be doing that. I'll ask my partner, Mr. Spencer, to assist with taking a set of baseline vitals. So, I will start assessing the respirations. Patient breathing at 28 breaths per minute. Adequate rise and fall. Lung sounds was clear. From the pulse ox, the patient has a pulse of 98. They were equal and a bit weak. Patient skin cool and clammy. Patient, asked my partner to do the GMR reading for the patient. Alright, I'll do it. Get a BP reading from this arm, alright? I'll clean the wound, I'll clean the finger. I will insert the strip into the machine, prick the finger, and pick up a drop of blood and get a reading of 1.1 millimoles per liter. Okay, this is indicating that the patient might be diabetic and suffering from insulin. Alright. Alright, so while my partner gets the BP cuff going, have you finished splinting the wound?
Yeah.
Okay. Alright, so this patient we will radio into the advanced people, advanced personnel, and inform them of what is taking place with this patient. He's a priority patient. He's unstable because he's unconscious. So we will be reassessing this patient every 5 minutes. After our partner has finished, I will do a detailed head-to-toe assessment of this patient to see if we missed any other injuries for this patient. So, I'll do a thorough examination of the head, checking to see if there's any bleeding on the gloves, checking the ears for any cerebrospinal fluid, checking the eyes. At this time, I'll notice that the mucous membrane would be pale and dry. I'll inspect the patient's nose, inspect the mouth, ensure that there is no vomitus again. Inspect the trachea to see if it's still in line, no JVDs. Thorough examination of the clavicles, inspecting the patient's rib cage, no flail chest. 4 quadrants of the patient's abdomen. I will assess the hip. Represent still in place. Examine the right leg. Left leg is still a bit shorter since there was no traction. And this patient will be continued to be reassessed. Every 5 minutes we'll check the wound to see if the bleeding has subsided, and continue reassessing the patient all the way to the hospital. Arriving at the hospital, we'll hand over the patient to the nurse at the A&E department at Cornell Regional Hospital. Okay, so this patient is an adult male. I don't even remember his age at this time. The adult male fell from the tree. Patient got up, made a few steps and fell, collapsed again. We found him on the left lateral position. Patient was unaware of us approaching, respond to pain. Patient had a 4-inch laceration to his right forearm. It was actively bleeding. Bleeding was secured with a direct pressure, then a pressure dressing. patient had a GMR of 1.1 millimoles per liter. Patient was also given oxygen at 12 liters per minute. Patient was breathing slow, a bit rapid, and patient's pulse rate was, patient pulse was what, 98? Patient also, alright, so yeah, we'll give this set of vitals that we got, all the interventions that we did for the patient, and hand over the patient. We will then remove our gloves, pinching, pull it off, roll it in the fist of the other, insert one finger, and take off the gloves of the other hand. Throw it in the bin, wash our hands, prepare our report, and hand a copy to the receiving personnel, and return to station. Thank you.